All the audience of West Bengal Academy of Pediatrics organized Listen to the Legends. Today it will be delivered by none other than our past president of 2026, Dr. Pramod Jog sir. And the whole Listen to the Legends session will be moderated by Dr. Sumita Naik. So Dr. Pramod Jog is very famous for his mnemonics. With his permission, I just want to share my mind. Pramod and JOG. P for mnemonics. Sir, you are very fond of it. R for remembering. A for authentic. M for master. O for outstanding. D for doyen. You are always joyful, sir. J for joyful. O overactive. Still you run the cycle to your chamber, as you have shared with me. And you are the Gurudev. So with this, my showing my respect, I will hand over it to Dr. Sumita Naik to introduce you. Over to you, Sumita ma'am.
Good evening to all the viewers. Thank you so much to West Bengal Academy of Pediatrics for giving me this opportunity, the wonderful opportunity to moderate none other than Dr. Pramod Jog. Thank you, Dr. Sapan Ray and Dr. Kripa Sindhu Chatterjee, for this opportunity once again. And also thank you for the mnemonic with which you have introduced Sir. So Sir is known for his jogisms, but besides that, I'm going to introduce Sir very, very formally. Dr. Pramod Jog is a professor of pediatrics and head of the family medicine department at the D.Y. Patil Medical College at Pune. He was the president of the Indian Academy of Pediatrics in the year 2016 and the former standing committee member of the International Pediatric Association as well. He was also the former steering committee member of Gavi, as well as the consultant pediatrician at MedPoint, Jupiter, Dinanath, Ankura hospitals at Pune. So several hospitals, Sir has been a very, very active. I would say he is probably one of the youngest pediatricians today. Thank you so much, Sir. Sir is also always there with us on any program that we invite him to. He's definitely there. So I'm sure we are going to have an excellent session of learning this evening. Over to you, Dr. Pramod Jog.
Thank you, thank you, thank you. I will just start with sharing of my screen, and I hope the slides are seen. Are they visible? Yeah. Yeah, I hope I am audible and slides are visible, right?
Yes,
Okay.
sir. Yes,
Yeah,
sir.
thank you, thank you, thank you. And then thank you for those kind words about me. And this epidemic of mnemonics is probably going to spread. And I already have a mnemonic for Sumita, and that stands for a scientifically updated, meticulous, intelligent trainer academician, because she was the trainer for the IAP WAC, which we concluded in the month of November last year. And of course, we will be discussing today about the immunization errors. And, the topic that I have taken up is vaccination vigilance. And you can see that there are certain, alphabetically, L, so there will be 5 L's here. So, basically the word legend has two meanings. One is legend, is something like an interesting story, and a legend is also a word used for an exceptional personality. So for today's presentation, I will just say that, it's related to so many different stories, the legends, and I am a lifelong learner, so I have put it as LLL. So we will listen to the legends of a lifelong learner. That's why there are 5 L's in this particular slide. And then all of us are aware that, whenever we, give vaccine, when we administer vaccines, so there are many problems which can come up, which we can just think offhand. For example, if the injections are not sterile, it can produce, some local injection site reactions, or there could be sepsis in case if we reuse the disposable syringes, or in case if the sterilization is not good, we might land up into a toxic shock syndrome, or problems like local abscesses, or in case if there are certain other medicines which are mistakenly administered for vaccines, like say insulin or muscle relaxants, then there could be problems related to those drugs. And that's why it's very important that we understand the nitty-gritties of this particular topic. And basically, it is always said that a vaccine administration error can lead to so many consequences. One is, of course, if there is some error, the error becomes evident, and the patient, obviously, rather becomes shaky, and it's possible that he loses the confidence in you. And of course, in addition to that, the immunological protection offered by the vaccine may go down. There could be a possible injury, harm to the patient. It may cost because the vaccine may be ineffective and you might have to use another shot. Okay. And it's, of course, inconvenient to everyone. And in general, people might have reduction in their confidence in the healthcare delivery system, which may lead to vaccine refusal or hesitancy. So it has, long pervading implications. And that's why it's better that we prevent these errors. And of course, when we do that, we have to remember that we have to report. And if there is something major, we need to investigate. For example, if there is, occurrence of these problems at a larger scale, we need to investigate. And day by day, in case if we improve ourselves, then it adds to the quality improvement. So with that small little background of this particular topic, I must tell you that everybody must understand that vaccination and immunization are not the same. Vaccination is simply the act of introducing the vaccine into the system, and immunization is the process by which a person gains immunity or protection. And we all know that there are certain important terms like seroconversion, which simply means that there is rise in the antibody titers; seroprotection, which means capability of preventing the infection; geometric mean titer, which is nothing but the mean of the antibody titers in a given population. And then, of course, there are terms like efficacy, which is ability of the vaccine to protect under controlled clinical conditions. And effectiveness is something, wherein the vaccine is brought into the use in the market, and effectiveness is affected not only by the efficacy, but it's a combination of what is the percentage coverage of the vaccine in the community, along with the herd effect, if any, for that particular vaccine. And in case if it has a good herd effect, the effectiveness could be higher, or it could be lower if the cold chain is not maintained properly, or if the techniques used are faulty, or the coverage is poor. I always love to give the example of different terms related to these terms like seroconversion. I usually equate it with love at first sight. So whenever a boy and a girl look at each other, many times there is love at first sight. That's only a conversion. One doesn't know whether it will really lead to engagement. That's the seroprotection. And one also doesn't know whether it would be efficacious. So I always compare efficacy with the marriage, because marriage is nothing but in front of all the relatives. It's a controlled clinical condition, it's a clinical trial in presence of all. And effectiveness, of course, is the behavior of the couple post marriage, and that is effectiveness as to what is the behavior of the boy and the girl after they get married, and where the blood pressure of the father-in-law increases, and whether the fights between the father, the daughter-in-law and the mother-in-law, they begin, and so on and so forth. So just remember that these are the different terms which are related to the example which I gave you. Anyway, so now we will have a detailed look at the errors related to immunization, and then of course what happens when we start immunizing neonates. I remember a pediatrician, understands that 0.1 ml dose of BCG taken by him is to be given intradermally. But, in the beginning of the practice, usually it goes subcutaneously by mistake. And then I remember a pediatrician who again took 0.1 ml in syringe and gave the intradermal BCG correctly at the second time. Okay. Now the question is whether it is right or wrong. Remember, whenever you give any vaccine for the first time and through mistake it goes into the system at a different site, we all know that BCG needs to go intradermally, but it has gone subcutaneously. Now first thing is, don't panic. Okay, so I understand that giving intradermal injection is a great skill and we acquire it over years of our practice, but then doesn't mean that the subcutaneous dose of BCG has gone a waste. Okay, I understand that it's not something which has been done right, but then please do not repeat the dose, because whatever amount of immunity is obtained by that subcutaneous prick of this BCG which has been given, will definitely have some effect, and then we will have to be observant as to what happens in future. And this is a very familiar picture for all, where after noting this particular complication, a pediatrician did the incision and drainage with the help of a pediatric surgeon, and the histopathology and the Ziehl-Neelsen stain revealed acid-fast bacilli. Okay, and that's why he immediately resorted to anti-tubercular therapy and amoxicillin clavulanic acid to be on safer side. Now there are plenty of mistakes which this gentleman has committed. So please remember, we all know that BCG does produce problems like either a non-suppurative lymph node enlargement or a suppurative lymph node enlargement, but it's a sterile abscess, and then it is bound to show you acid fast bacilli. So anticox therapy and secondary antibiotics like amoxiclav are not advised. Okay, now there is one interesting story which happened where this nurse in the hospital, what she did was, instead of giving 0.5 ml of hepatitis B at birth, she took 0.5 ml of BCG mistakenly and gave it intramuscularly on the thigh, where we usually give hepatitis B vaccine, and zero point 0.1 ml of hepatitis B was given intradermally in the arm. Okay, but the pediatrician immediately understood the mistake, and to ensure that the BCG mark should appear on the arm, he was very smart, because the scar has to be seen. So he again took 0.1 ml of BCG and gave it intradermally on the left arm, and hepatitis B on the other lower limb. That was, of course, 0.5 ml. Okay. Now, he did not reveal this to the relatives out of fear, but he did not know what to do next. And then remember that 0.5 ml BCG given in the thigh is quite a huge dose. What to do with that? The answer is, of course, not very simple. We have to wait and watch. Okay, that is because the BCG, we are not going to repeat it again, because already it's a massive dose. What happened in this child was there was a big abscess, and of course over a period we had to rather do the excision of that. It was something which was not very expected, but then was expected because the huge amount of BCG dose was given. Then what happens to that hepatitis B? This is very important. Hepatitis B, which was given in the dose of only 0.1 ml intradermally, is something scientifically we must remember, that there are certain vaccines which have to be given intramuscularly. And what should we do if we give an injection by the wrong route? So the route given here for hepatitis B, which was of course intradermal, was not a right route. So there are 4 vaccines like hepatitis B, rabies, HPV, and inactivated influenza vaccine. In case if they are administered subcutaneously, the dose should not be counted as valid and should be repeated. This is the most important thing. So in case through mistake you administer these vaccines in a different route other than intramuscular, you have to be very, very careful. Okay. Some other stories related to BCG, like a newborn being given BCG and has been explained that there would be a scar later. Okay. So the mother says that 4-year-old son has no such scar, and she is asking you whether he needs a repeat dose. Okay. Now remember that no scar does not mean failure. Okay. In the absence of a scar, we know that in case if a newborn is given BCG and he develops a scar, everything is fine. But even at the end of 6 months, if there is no scar, then one can repeat the dose. But it's only once. You have to repeat only once. Now, for this 4-year-old son who has no scar, actually there is no need to repeat the dose, because in 15 to 20% of cases we may not get the scar. And of course, up to the age of 5, you can very well repeat BCG, but only once. However, many times, you have to take a decision after discussion with the parents. Up to 5 years, there is no, reason to worry about repeating. You can repeat, but you can always tell the parents that mostly the vaccine works, and absence of scar does not mean that the vaccine has failed, because the reason that a child gets scar is the injection. The proteins in the vaccine, they are the ones where there is a papule and there is an abscess and then it bursts and then there is a scar formation. So it's not connected with the immunological protection. Okay. Another, relative from USA with a 6-year-old child and a 1-year-old child who have come to India. But both have not received BCG because they were born in US and US doesn't give BCG. So they will be here for about 4 months. So do they need to take BCG? Okay. Now here one must remember that the 1-year-old can be given BCG vaccine without doing one-two test. Okay. BCG can be given till 5 years of age without doing a prior one-two, and BCG is not recommended beyond 5 years. However, it can be given to the high risk cases, particularly to children, adolescents, or adults who are 1-2 negative. Okay, so that is the way you have to handle these, parents who come from abroad. Now, an interesting case where in one of the hospitals where I visit, there was a patient with urinary bladder malignancy, and you know that the therapy these days in the initial part is immunotherapy for CA bladder, and for which onco BCG is given. And the nurse, in the same hospital, it's a general hospital where neonatal unit is also there. When she was asked to get the BCG, she brought the BCG from that onco BCG. Okay, remember this onco BCG, even 0.1 ml. So that is almost 100 to 300 times more potent than our usual BCG. Okay, and then that was injected, and later on, of course, it was noticed. But then, of course, nothing is to be done. As I told you, in case if you have given a vaccine, usually you have to wait. And here, masterly inactivity is something which is to be observed. Wait for 6 months. Just see as to what happens. And then, depending on the progress, you can take a decision. Okay. There are some situations where by mistake, excess polio drops are administered. Okay. And, remember that nothing happens even if you give more than the usual 2 drops of polio. Maybe that because of phenolphthalein in the polio vaccine, the child may get bit of diarrhea, but otherwise nothing happens and you are not supposed to panic. Okay. There are some situations where, an infant got a dose of adult formulation of hepatitis B in error. And we are thinking whether the dose should be counted. Okay. That means it was almost the double dose. So if it happens like this, please remember that if an infant receives an adult dose containing the twice the antigen in a dose of the pediatric formulation, the dose can be counted as valid and does not need to be repeated. Hepatitis B vaccines are very safe vaccines, and no unusual adverse events would be expected because of this particular administration error. Of course, the next dose should be given on the usual schedule. We need not be concerned about any adverse event. Okay. Now, a parent of my child patient came for hepatitis B vaccination. He was the father. And as per my usual habit, took 0.5 ml dose and gave it, and completed 0, 1, and 6 month series in the same way for the father. Okay. And after long back attending a vaccinology webinar, I realized that there has been a big, a problem because the dose which was given was half. And now what to do? Okay. So in Hindi here we say, Teri bhi chup, meri bhi chup. That means you also be quiet, I will also keep quiet. So at that time, of course, in my younger days, I kept quiet. And then I discussed it. And then I, of course, came to a conclusion that if certain thing like this happens, if you come to know that you have given a lesser dose, say 0.5 ml instead of 1 ml, if you realize it on the same day, then you can give the remaining dose on the same day. Suppose it's 12th of April and it happens, say, around 11 in the morning, up to 3, 4 o'clock, you can repeat, rather not repeat, but give the additional 0.5 ml dose of hepatitis. But if you come to know it little later, then it is always better to give the full adult dose. However, here what had happened was although the entire series was over, okay, 0, 1, and 6 months. So after that, we really kept quiet. But in case, if it are very, very, very particular, you can do the antibody titers and decide whether this gentleman has developed adequate protection or no. Okay. Remember that certain things related to a preterm infant are to be noted, though these are some important issues. That's why I have just projected this slide. So a preterm infant weighing 1900 grams, born after 34 weeks of gestation to a hepatitis B positive mother, what should be done? Now, everyone probably in the listeners group knows that hepatitis B immune globulin is to be given within 12 hours of birth, along with the first dose of hepatitis B vaccine, with 3 doses of hepatitis B at 1, 2, and 6 months, And then seroconversion should be documented by testing the antibodies at 9 months of age. If hepatitis B immune globulin is not available, then give birth dose of hepatitis B plus 3 more doses of hepatitis B at 1 to 6 and 12 months, and 1 2 and between 6 and 12 months. And remember that the efficacy of hepatitis B immune globulin plus hepatitis B vaccine together is almost to the tune of 85 to 95%, and 4 doses of hepatitis B vaccine, the efficacy is 70 to 75%. This is for the information of our audience. Okay. Now, certain case scenarios related to the whole cell pertussis containing DTP vaccines. The question is whether a 2-month baby diagnosed to have cerebral palsy following birth asphyxia be given DTWP. As you know, cerebral palsy is a static neurological deficit. Okay. There is another case where a 5-year-old has idiopathic epilepsy and has come for the second booster dose. Can he be given whole cell DTP vaccine? Okay, because there is some neurological problem. We want to know whether we can give this particular second booster dose. Then there is an 18-month-old who had viral encephalitis 5 months back, and whether he can be given DTWP. And a scenario where a child had febrile seizure at 9 months, can she be given the 18 months DTWP? So the answers to these are, of course, that a child who has a static deficit, you can always give DTWP. If a child has idiopathic epilepsy, yes, you can very well give it DTWP. 18-month-old who has viral encephalitis, static encephalopathy is not a contraindication for DTP. And remember that if a child has had febrile seizure at 9 months, one could preferably use acellular vaccine for its low reactogenicity. So one should remember that different situations we should be clear so that we do not commit any mistakes. And of course, everybody knows that anaphylaxis is an important contraindication for wholesale pertussis vaccine, and these babies should not be given DPT in future. Now, this particular term contraindication and the other term precaution, the area, the gray area between the two is there. That means it is not very clear cut distinction that this is a contraindication, this is a precaution. Many times we have to individualize our decisions, and in case if there is encephalopathy within 7 days of receiving this wholesale pertussis vaccine without any other cause, then we will probably not use pertussis component but give only DT. Or if there is a progressive or evolving neurological disease, certain experts, they take it as a contraindication, while some people say that we have to take certain things as precautions. Like, for example, there is a rule of 3 that the child is inconsolably crying for more than 3 hours, has fever above 103, and he has this hyporeflexive encephalopathy within for 3 days. So we have to be rather very, very careful in looking at the child and taking the decisions, though the absolute contraindication remains to be anaphylaxis. So let us see certain situations. So after giving acellular vaccination for primary series dose, the patient had come back for follow-up after 3 days. Okay, and the grandmother is not happy with me. She says that the vaccine given by me was not potent as there was no local reaction. She was expecting that there should be some fever. Okay, so she went on saying that that is why government vaccines are better than private. Here in private, you don't get that reaction, so that children are not getting any protection. Okay. So in spite of saying not to rub on the injection site, the grandmothers are always adamant about rubbing the vaccination site, and that too aggressively. So remember, my dear friends, that we have to respect WHO. WHO is not our World Health Organization. It is the wife, husband, and others. Okay. Who are the others? Which includes grandmothers predominantly. Okay. Because their opinion matters in the house. Okay. The wife and the husband have no value after my lot of experience of so many years. So remember that the grandparents are the ones who are important. So you have to always see that they are convinced properly. Okay. Now, patients relative trouble me a lot if they get fever after vaccination. Okay. So somebody may say that I have made it a protocol for my practice that I will give all of them paracetamol and tell them to give it to the baby for 2 days, irrespective of whether fever is there or not. Is it a right practice? Remember that there are experts and there are reports which say that after the first injection of DPT, if you give paracetamol prophylactically, particularly the immune response may be blunted. And that is why the better policy would be to give paracetamol only if the child develops fever. Then another situation, along with DPT containing vaccines, we give rotavirus vaccine. So it so happens that many mothers I have seen, they go to their mother's place, and just to avoid that their mothers are not supposed, rather required to pay a lot for those costly vaccines like PCV and rotavirus and others. They postpone the vaccination. Okay, they don't realize that postponement of rotavirus can make their babies susceptible to get into susception if rotavirus vaccine is given later. But of course, they won't know all this. So what happens is they come after 14 weeks and 6 days, which is the age for the first dose of rotavirus vaccine. So they come at 16 weeks. Now the question is, they have come basically for the DPT, IPV, HIB and others, the pentavalent vaccine. They may go to the, rather they would come first to the private clinic and ask me, sir, what to do. Now your problem is, at 16 weeks already the age for the first dose of rota is over. What do I do? Okay, so whether we can continue with the second and the third dose later. So this is a very tricky situation, and usually what I do is, to be legally safe, I refer these babies to the government setup, because in the government setup we can always give rotavirus vaccine doses up to 1 year. Okay, and that's why, to be legally safe, I do that. However, there are many of my friends who do not bother much about it, and they give rotavirus vaccine, they do give it, and they have not yet landed into any problem. I know that, but it is not in black and white anywhere. Of course, remember that the first dose of rotavirus vaccine should be given before 14 weeks 6 days, and the third dose should be completed by 32 weeks. We are still bound by this particular dictum, and that's why please remember that the vaccine should not be given beyond the recommended age. Okay, there are some times where the parents say, doctor, my baby has vomited the rotavirus vaccine immediately after you gave it. Okay, so the best way is to give the baby onto the lap of the mother and put it on the inner side of the cheek. I do it, but many times it so happens that in the busy practice, the babies, whatever you do, they vomit. So what I have started doing is, of course, I hand over this vial of rotavirus vaccine into the hands of the parents, particularly the mother, and ask her to give that vaccine to the baby. So if the baby vomits even after administration by the mother, the cost of the vaccine is not to be borne by me. Okay, of course, the lighter vein apart, just remember that you have to take a proper precaution by giving the vaccine on the inner side of the cheek. Okay, now a 2-month-old baby was mistakenly given this pneumococcal polysaccharide vaccine 23. And what should be done? We all know that PPSV 23 is not effective in children younger than 24 months of age, and it is given at this age, which should not be considered to be a part of the pneumococcal vaccination series. So pneumococcal conjugate vaccine should be administered as soon as the error is discovered. Okay, anytime the wrong vaccine is given, the parents should be notified. Okay, and now, as I told you, a patient of progressive neurological illness was not affording the acellular vaccines, so he was given DTWP for the 18-month booster dose, and the patient had fever and convulsion which lasted for 1 minute only. So whether it was a mistake, as I said, a progressive neurological illness is usually taken as a contraindication by a lot many experts. However, we have to be very, very careful. And the term precaution is something which we must understand. What do you mean by precaution? Precaution means that the parent should be explained that please try to come in the morning hours. In case if something wrong happens, we will be able to handle it better. This particular problem had occurred at the first instance, and we will have to be careful at this time. So all those situations which we had enlisted, where I told you the rule of three, they come under precautions. Sometimes it happens that Tdap is given as a 4 to 5 year booster. Okay, this is to be avoided. Tdap is used above 7 years of age. Okay, as you know, the antigenic content of Tdap is lesser, and in case if inadvertently it is used, it will be considered as a valid dose, but it is to be avoided as a 4 to 5 year booster. Efficacy achieved is suboptimal because of the reduced antigenic content of Tdap, and rapid waning of antibodies is noted, particularly for the pertussis component in Tdap, and it remains for a very short period of about 3 years only. So the error is administration of the wrong vaccine. So administering the wrong vaccine due to similarities in the vaccine names is very common, and that's why you have to check the vial label 3 times. Okay, 3 times. So remember that such errors often involve vaccines whose generic or the trade names look or sound alike. Okay, and remember that you have to check the vial label 3 times. Just have a look at these. So here you can have either tetraxim and pentaxim. They look so very similar. Okay, the figure 3 is something which has come out of psychological analysis, and it has been found that if you look at 3 times, then that is the best number which would give you very very clear cut guidance. Of course, rule of 3, in my particular life I use it in a different way, and in fact my wife has also learned this rule of 3. So whenever I come back from the clinic, then usually she wants to tell me something. So she makes me wait for 3 minutes. Then, during that time, she offers me a cup of coffee along with maybe some idli vada or something. And then after 3 minutes, then she tells that her mother is going to come and stay for 3 months. Okay. So that is the technique. That is the rule of 3 for her. Anyway, so Pentavac SD and Servavac. See how closely, they resemble each other. So remember that you have to be very very careful, and in case I will tell you in one of the cases when more than one family members rather comes, then you have to be very very careful. So this is that case where two brothers like Ram and Lakhan, so this adolescent boy had come for the Tdap, and younger one had come for the first booster, but through mistake Tdap was given to the 18-month-old and this pentavalent was given to the 10-year-old. Now what is to be done? So the first situation where Tdap, as I told you, though the immunological response may not be adequate, it is valid, but we'll have to repeat it because that 18 months baby only received T, D, and P, and the baby has not received IPV, neither this other components like HIP and all. So it has to be repeated. Now, if you have given pentavalent vaccine to the 10-year-old, the only problem could be reactogenicity. Of course, the full dose of all the antigens have been received. Okay. So the best policy is to allow one chap, one boy, or one girl at a time. So one at a time, one file, one patient. Do not allow two patients at a time. So otherwise it creates confusion in the busy practice. Okay. So you can understand now that these vaccine administration errors are either related to insufficient staff training who fill up the syringes in a wrong way, or distraction while working, people keeping looking at the mobile phones or chatting with people on phones, or changes in the recommendations of some protocols which takes place, or the patients are misidentified, or there are some misidentified products like DTAP, DT, TDAP and TD and others. Okay, so a systematic review of the medical literature was done. It was almost a 9-year meta-analysis, wherein it was found that the most commonly reported vaccination errors were wrong vaccine administered and off schedule administration. Okay, a few more examples where a 10-month child has shifted to you after receiving the national immunization program vaccines. So he has already received 3 doses of fractional IPV, as we know, at 6, 14, and 9 months, 6 weeks, 14 weeks, and 9 months. And then seroconversion after the 3 doses of fractional intradermal IPV is in the range of almost 98 to 99%. So another IPV is not required. So these parents have come to you to ask you whether the vaccine that they have received, the 3 doses in the national immunization program, whether additional polio doses are required. So another IPV is not required in the first year, but you can suggest them to take boosters at 18 and 60 months as per our guidelines. Okay. Now this is the story of 1985. I call it as 1985 a sea page story. What is that story? In Aurangabad, which is a town in Maharashtra, some 5 deaths occurred following measles vaccine. And I was a part of the investigating team at that time. And what had happened was multi-dose vial of measles was available at that time. And the nurse had prepared the vaccine at 4 p.m. earlier afternoon. And the multi-dose vial, which was prepared, was kept in a earthen pot and kept cool by keeping cold water in that earthen pot. And what had happened was that the water had seeped into the bottle through the rubber cork, and children had toxic shock syndrome. And it was quite a prominent story at that time. And then, of course, this was related to those multi-dose vials. It is always to be remembered that we have to use single-dose vials. Fortunately, most of the vaccines these days are available as single-dose vials. Okay. Now, particularly some issues related to those vaccines like MMR and others. So, if the patient is not comfortable with 2 injections on a single day, it happens that you give him a 15-month MMR vaccine and calls him for varicella vaccine. But if the pediatrician calls him after 15 days and administers it, it is a mistake. Okay, so it's a mistake. So we all know that giving 2 doses of live injectable vaccines very close is something not acceptable. So two parenteral live vaccines can be given on the same day, and if administration is less than 4 weeks apart and not on the same day, the second given vaccine is considered invalid, and the repeat dose should be administered after 4 weeks after the invalid dose. Okay, MMR and varicella either given on the same day, or if not, 4 weeks interval should be maintained. Okay. Now, sometimes it happens that in a hurry to go for a movie, the patients come running, and at the last minute, I remember patients coming for varicella vaccine. I took out the liquid from the vial and injected it. And when I was throwing entire waste in the dustbin, then I noticed that the powdered vial was still intact. Okay, what had happened was I had injected only the diluent. So, my dear friends, remember, you have to be very careful. So, using the wrong diluent or administering the diluent only are errors which are very common. So, please be careful and check the vial and the diluent labels 3 times before reconstituting vaccine, and be very vigilant. Okay. Now, please remember that check the vial and diluents label 3 times before reconstituting the vaccine. Okay. I have 18-month child has received 2 doses of MR. We know that in government we give MR at 9 months and 16 months. And how many doses of MMR now does he need further? Because the parents have come to you and they want MMR now. So remember that if a child receives 2 doses of MMR in government, they must receive at least 2 MMRs, one now and second one at 4 to 6 years. We know that the 4 to 6 year injection is particularly for the mumps component. Okay, a 8-month-old baby was erroneously given varicella vaccine, and what might be the consequence? We know that varicella vaccine is given beyond 12 months. Okay, so what should we do now? So 8-month-old is likely to have residual passive varicella antibodies from the mother. So the vaccine probably will have no effect, and that's why no action is necessary. The dose should not be counted, and the child should be revaccinated on schedule at 12 through 15 months of age. Okay. And the child received her first dose of varicella vaccine when she was 12-month old, and the second dose when she was 14-month old. Now, the second dose was only 2 months after the first. So, is this second dose valid, or does it need to be repeated? So, the recommended minimum interval between 2 doses of varicella for children 12 months through 12 years is 12 weeks. That is almost 3 months. Okay. However, the second dose of varicella vaccine does not need to be repeated if records show that it was separated from the first dose by at least 4 weeks. Okay. Now you have administered the vaccine and affixed the sticker on the child's vaccination card, and 10 minutes later, the father walks in and, rather agitated, says that the vaccine has expired 3 months back, and this has been administered to this child. And how will you manage? I'm sure every one of us at some stage of the life has encountered such a situation, and one is that you must accept your mistake if certain thing like this happens. Please assure that no adverse event will happen. If the parents listen from your mouth, they are reassured to a great extent. Okay, offer to give the vaccine again. Do not charge if you repeat the vaccine again. Please remember that this is very important, and everybody must be very, very clear about this, that you have to rotate the stock in the storage unit, which means that you have to make sure that the vaccine that expires soonest is the closest to the front and easiest to reach in your storage unit, and establish a regular schedule for checking the storage unit. And the dose should be repeated. As I told you, if the expired dose is a live virus vaccine, for example, you give chicken pox, and then you understand that it was already expired 3 months back, then you wait for 4 weeks before you give varicella vaccine again. But if it's a killed vaccine, then the dose can be repeated as soon as possible. Okay, although simply repeating the dose is preferred, serologic testing to check for immunity after certain vaccinations may be acceptable. Of course, this is sometimes not very practical. So again, check the vial 3 times. And after encountering such a situation, sometimes I have started, letting the parents check the date before administering them. So I just hand it over to them, just show them that please check the date, and then to increase the transparency and prevent problems, I, let the parents check the date before I administer. Okay. But then again, remember, check the vial 3 times. So remember, the figure 3 is very important. Okay. And also remember that let the parents check the date before you administer. Now, in case if we administer the vaccine in the wrong site, okay, we all know that either anterolateral aspect of the thigh or deltoid are the preferable sites. But at deltoid, we have to be careful about what is called as SIRVA, that is shoulder injury related to vaccine administration. So in case if we administer it too high, there could be a risk of injecting into the shoulder joint or the bursa, or you can cause inflammation leading to bursitis or frozen shoulder in the older chaps. And in case if you inject it too far to side, then you can inject into axillary nerve. If it is too low, it can go into the radial nerve. And that's why you have to remember that 2 to 3 fingers down from the acromion is the location where you have to give this vaccine. And obviously, do not use the gluteus for vaccine administration, and particularly any rabies vaccine. If you find that the first dose was taken somewhere else and the nurse gave it in the gluteal region, please remember it is to be taken as invalid. Okay, because the absorption in gluteal area is absolutely erratic. Okay, and then the administration of vaccine using wrong needle is another error. So you have to remember that for subcutaneous, it has to be 26 number half inch. For intramuscular, it has to be 23 or 24 1 inch. And for intradermal, it has to be 26 or 27 half inch. Okay. And a 20-year young man traveling to US for further studies, he received the first dose of MMR and varicella on 24th of June last year. The second dose of both the vaccines was due on, say, 24th of July, but then it was administered on 19th July as he was traveling on 21st of July. So whether this second dose of both these vaccines valid? So this brings us to the concept of what is called as the grace period. So giving a vaccine dose earlier than the recommended age or the interval or beyond the age of recommendation. So a dose administered 5 days or more earlier than the recommended minimum interval is considered as invalid. Suppose today is 12th of April, and if in case this next dose is due on say 10th of May, which is after about 28 days, and if the child comes on 3rd of May, then obviously it is more than 5 days, earlier than the recommended date. So the doses administered 5 or more days before the minimum age should be repeated on or after the patient reaches the minimum age. It also happens, sometimes that the baby has to receive the first dose of DPT or the DPT containing vaccine at 6 weeks, and the baby appears quite chubby, and you mistakenly feel that it is already 6 weeks old and the baby is only 35 days old. What to do? So in case if through mistake you give the vaccine, you have to remember that it was 5 days before the due date when it was to be given. So you have to repeat it. Okay. And then a 16-year-old received HPV vaccine third dose 12 weeks after the second dose, but only 4 months after the first dose. So whether the third dose should be repeated. So all these issues are related to the interval And if HPV vaccine is administered at lesser than the recommended minimum interval, then the dose should be repeated. Okay, my dear friends, remember that the error is in the wrong or the inadequate dose. So sometimes it so happens that the needle gets separated from the syringe while you are injecting. Okay, sometimes the needle is fitted loosely. Okay, and then while giving the vaccine, approximately half of the dose, flies off into the air, and then whether we need to revaccinate, what to do. So if only partial dose is injected, the dose is not valid. Okay, so repeat the full dose immediately or at any time for inactivated vaccine, but repeat the full dose after 4 weeks for live vaccine. Please remember, this is very common. Children move their limbs like anything, and that's why you have to stabilize them. If it's an adolescent, he's an adolescent or she's an adolescent, explain what you are going to do, and then they will cooperate better. So this is very important. Otherwise, wrong or inadequate dose may enter into the system, and this will have no immunological benefit. Okay, so while administering the vaccine, in case if blood appears in the syringe on aspiration prior to intramuscular injection, what is to be done? Again, a common problem. See, aspiration before injection of vaccines or toxoids is not recommended because no large blood vessels are present at the recommended injection sites like deltoid or the anterolateral aspect of thigh, and process that includes aspiration might be more painful for infants. However, if you do aspirate and get a flash of blood into the syringe, then the procedure is to withdraw the needle and start over again. The syringe, the needle, the contaminated dose of the vaccine should be discarded. What happens is when the blood comes into the syringe, blood has a different pH, blood has different proteins and so many other things. So the constitution of the vaccine changes, and what you are injecting inside again is something which is not immunologically very potent, and that's why a new syringe, a new needle, a new vaccine, and a new site is the rule. In case if you aspirate and if blood comes, please do not re-inject the same vaccine which is mixed up with the blood. Okay, so remember, do not do what you should not do. So do not aspirate because you are not supposed to aspirate. Okay, and of course, never ignore immunosuppression. I will not elaborate more, but just remember that you have to wait for at least a month after discontinuation of the therapy or reduction of the dose of steroids before administering the live vaccine, and particularly who have received high systemically absorbed doses of corticosteroids for 2 weeks or more. Okay. Of course, there are some important rules related to immunosuppressants like methotrexate and immunosuppression due to rituximab. Remember that this particular medication is used many times for the antiphospholipid syndrome and so many conditions. So at least for 6 months following the treatment with these lymphocyte depleting medications, for both inactivated and live vaccines, both these vaccines should be withheld. Okay, and remember, there are many who give tetanus toxoid for every injury every time. Okay, but this is simply not done, and there are definite protocols as to who are to be given TT. Okay, so if in case the child has received less than 3 doses, or you do not have, you are not very certain about the immunization status, and in case if the wound is not very clean, then you can give tetanus vaccine and tetanus immunoglobulin, and you have to be very, very conversant with the history of tetanus vaccine, the type of wound, and then you can decide whether the vaccine and the immunoglobulin need to be given. So, to prevent all these errors, there is something called as a screening checklist, which gives you contraindications to vaccines for children and the teenagers. And this list, which contains about 15 questions, tells you whether the child is sick today, whether he has any allergy, whether he has any serious reaction in the past, and so on and so forth. So it's always better that in your immunization clinic, you use such a list so that this particular vaccine that you are going to give, whether there is any contraindication. And of course, never ignore rabies immune globulin or monoclonal antibodies in the rabies patients. One simple test is, that you have to apply the spirit onto the wound. If it, produces little bit of tingling sensation, then this means that the nerve is exposed, and then you have to administer rabies immune globulin. So remember that indicates category 3 exposure. So always, whenever a patient comes to you with class category 3 exposure, you are always supposed to administer rabies immune globulin. In case if you are not sure of the availability, at least write on the paper advised RIG. This is for medical legal reasons. And always document the vaccine given to the child in the vaccination record. There are plenty of errors related to cold chain, but always remember this particular picture, which tells you that the most heat sensitive vaccines are, of course, oral polio vaccine, rotavirus vaccine, reconstituted BCG, and those ones. And the vaccines which are sensitive to freezing, of course, are hepatitis B, the topmost one. Okay, remember all those containing T in their names, like TT, DPT. Basically they are least heat sensitive and least cold sensitive. That's why the way we store these vaccines is different. So you can see that the oral polio vaccine, BCG, rotavirus, and others, and the freeze-dried vaccines like varicella and MMR and others, they could be kept at the topmost compartments, while all those containing T are at the lowermost compartment. Of course, I am sure that all the listeners are well versed with whatever I'm telling. Okay, there is a concept of vaccine vial monitors, and as you can see, the number of the vaccine vial monitor 30, 14, 7, and 2. It is nothing but the reflection of the number of days to the end point at 37 degrees. Okay, so the least stable vaccine is like polio or rotavirus vaccine or the varicella, where the VVM2. That means as soon as the temperature remains at 37 degrees for 2 days, then many times it changes its color. Okay, so VVM can be observed frequently, so that you come to know whether the stability of the vaccine is intact or no. Okay, and then of course a last situation where a 12-month-old child suddenly stopped crying after vaccine prick. He was excessively irritable before and during the prick, and everybody, held this baby tightly, and respiratory movements were not seen, and the lips were bluish. And then the relatives started shouting, "Reaction, reaction." I got panicky. I started bag and mask, started IV fluids, gave adrenaline, and the child was all right within 3 minutes. And the relatives and myself, both of us, thanked the God. What had happened was, it was not an anaphylactic reaction, but basically this was a breath holding spell. You know that after crying, children throw a breath holding spell. Okay. However, it is always better to overreact in such a situation, because already you are given the vaccine, and treat it as anaphylaxis. Okay, so there is a difference in fainting and anaphylaxis. There are certain vaccines like HPV where the adolescent girls also faint. I always say that the girls faint because the vaccine is being rather given by a prick, and the parents faint looking at the price of the vaccine. So both of them faint. Anyway, apart from the lighter vein in which I'm telling you, the point is that a female who has been given HPV suddenly falls, has a fall and becomes unresponsive. Whether this is anaphylaxis, usually no. Usually it is fainting, but you have to be ready, and that is why one should always remember certain important things, that you must have an emergency tray having adrenaline. You remember that adrenaline always has a very short expiry, so non-expired adrenaline with IV access, IV fluids, oxygen, resuscitation, umbu bag, and steroids, antihistaminics, and other resuscitation equipments. So remember that not using a screening checklist is an error. Administering wrong vaccine due to similarities in the vaccine names is an error. Using the wrong diluent or administering the diluent only is an error. Administering the vaccine dose earlier than the recommended age is an error. Administering the wrong dose for age and the of the right vaccine is an error. And administering an expired vaccine is an error. And not following standard procedures is an error. So remember that to err is human. Okay, let us not forget it. Of course, I always feel, let the parents take the role of forgiving us, because to forgive is divine. Okay, so remember, to err is human, but if an error is not a stepping stone, then it's an error. So you must learn every day from the error that you committed yesterday. So there are 6 steps to prevent the vaccine errors: right person, right vaccine, right dose, right time, right route, and right documentation. And of course, the right posture of the patient. Okay. So let us listen and learn from the legends of the legends. These are the stories which I told you from the experience, my experiences, my colleagues' experiences. And remember my name, Pramod. So no panic, rectify, in case if there is any problem, surely not to commit it again, manage it well. The onus is yours. Okay, be honest whatever you do. In case if it comes to repeating the vaccine at your own cost, do that, but be honest. Tell the patient that this has happened and doing it for the benefit of the child again, and document whatever happens. Okay. So I always feel that if everyone is going to give vaccines every day, everyone needs to be a vaccine champion. Thank you. And you look at this picture carefully. Those who do not retire on time can cause a lot of damage. Okay. Okay. With that, I stop sharing my screen. And in case if there are any questions, I will be more than happy to answer. And I'm glad that Dr. Sumita is around. So if I am unable to answer, she can answer because she is, in charge of the IAP VAC. So that's the wonderful course that she has been running for so many months now. Okay. Thank you. Thank you.
Thank you. Thank you so much, sir, for that elaborate and entertaining discussion. It didn't seem like a class at all. It was so interesting. So thank
Thank you.
you so much, sir. There are a few questions. I think we will take the questions first. So I think you have started very well. You started out with errors starting from BCG. So just to add to all that you have said, for the audience, you may not get a BCG scar in 10 to 20% of those who have received the vaccine in the correct route, correct dose, etc. So do not worry as long as you have it documented. Well, you don't need to do anything. So the first question here is, sir, if the influenza vaccine of NH strain is given in the month of March, should we administer SH strain before monsoon?
Not really. Actually, the dictum these days, or what usually the thinking is that give any strain vaccine, but give it. So if at all, I can understand that the NS strain usually continues, till the month of March or April, and the SH strain comes right, say, in the month of April. Already this year it has come in the month of March only. Okay. So in case if you have given the NH strain, then there is no great hurry of giving it, in immediate future. So just see that the prime and the boost principle has been followed. So if this child has already received 2 doses last year, then this year at least see that the child receives 1 dose, because priming and the boosting for influenza is very important. So last year, if at 6 month and 7 month the first and the second dose has been received, that means the priming has occurred. Then in the next year, the single dose can very well continue. So there is no great need of administering SH strain before monsoon, as per my opinion, unless there is a major change in the strains which are there in the SH strain. Okay, so as of now, we all aware probably that now the new vaccine which will come in the month of October probably again will be trivalent. Till now we were getting the quadrivalent, but that Yamagata strain which has not been observed in major parts of the world. That's why probably it is being removed, and a trivalent vaccine probably will come in the month of October. As of now, it is quadrivalent. But then, Dr. Sumita, in case if you have any inputs from your side, you can feel free to add to what I said. Yeah. Yeah.
Yes, sir. So actually, the answer, as sir has mentioned to this question, is there's no need to repeat. You need to do it once a year. And as sir has rightly said, you just need to schedule the next year's vaccine at the time when the SH strain comes in. Now, regarding the trivalent, yes, there is a move by CDC to change from quadri to trivalent because of the absence of the circulating Yamagata strains. The possibility that the companies will take it up for the next batch is very high. Despite the fact that India, there are some reports of Yamagata being found in circulation in India. So as of now, we do not have any information from any of the companies that they are moving. But then again, we have to wait and see what would happen probably at the next meeting when they discuss about the next strain. So whenever that happens, and then they will not produce anything specific for India. So whatever comes in, the multinationals will bring it into India and we will be requiring to use it. So the only thing is that please use whatever is the latest strain of the vaccine and give it once a year, as long as the child has already received 2 prior doses. So I think that's about influenza. The next one, you talked about the in improper dosing of the vaccine, the spillage. So the question is, slight spillage during administration of inactivated Hep A vaccine second dose. What should be done?
Yeah, actually, as I told you, this spillage can occur in case if the the needle comes out from the syringe or the child moves, something or the else happens. Roughly, if you are confident that more than 80% of the vaccine has entered into the system, then it all depends on your honesty, your perception, and the quantity of the vaccine that you feel has entered into the system. So if say 80-90% of vaccine has entered into the body of the child, then you can relax. Okay, but if you find that you just started giving the vaccine and suddenly the needle came out and a lot of vaccine just came out from the syringe and it was spoiled, then you need to be very honest and at your own cost see that you repeat the dose. Fresh needle, fresh syringe, fresh vaccine and a different site. Okay, there is no way out because that is what the standard standard of care says. Okay, but it all depends on again that particular amount of vaccine which has entered into the system. And at all these situations, cost should not be the major concern. Many of us are worried about the cost, that what would happen, why should I spend, and also that let not that thought come into your mind, because these things do not happen every day. Once in a while it may happen. It does happen, because the sisters many times, when they fit the needle to the syringe, many times they attach it very loosely, and you also tend to forget whether to confirm whether the needle has fitted properly to the syringe and so on and so forth. So you have to be careful, but you have to be honest. And in case if you find that a lot of vaccine has been wasted, then you better repeat it. Yeah, that's what I think about it. Thank you.
The next question is, why priming with at least 1 dose of WP at the beginning, not with other sequence like later doses suggested?
Actually, there have been quite a few trials, particularly from Australia, which have shown that if you give the first dose of the DPT containing vaccines, with which contain whole cell pertussis component, then the subsequent immunity with the second and the third dose, irrespective of whether it is whole cell or acellular, is of a great good nature. Okay, and this has been substantiated in quite a few studies later also. Though the major studies have come from Australia, there are people who feel that this is more of a concept than a scientific fact. And that's why debate continues about this, because there are quite a few vaccine companies which manufacture acellular vaccines, acellular pertussis containing vaccines. And that's why many times, they feel that this is, not a scientifically proved fact. Okay, but then in case if you go into the depth of the literature, this first dose of DPT containing vaccines, if it is containing whole cell pertussis component, then we will definitely have a better immunologic response. That is what is said, and ACVIP agrees, and the Purple Book also mentions about this very clearly. However, over a period, remember, immunology rather is a ever changing and a dynamic science. Okay, and some of these facts which we believe today, might change. Maybe next year some other study, a long term study may come up, and some of these facts may change. But as of now, the understanding is that the first dose of DPT containing vaccines, it is better that it is containing whole cell pertussis as a component. Thank you. Yeah.
So actually, that is because the whole cell, the WP containing vaccines are known to trigger a Th1 type of an immune response, whereas the acellular, the AP containing vaccines go more towards a Th2 and a Th17, which is more of an Ig kind of a response rather than an IgG. So having said that, as you rightly mentioned, sir, it is very, very dynamic. There is definitely no uh, guidelines as such which say in black and white that you prime with acellular and then prime with whole cell and then go on to acellular. There's no guidelines at all like that defined. There is a very recent paper which has come out from Thailand. Now, Thailand is having both the vaccines akin to India. They have the WP as well as the AP vaccines. And what they did was a very interesting study where they have checked the levels of the anti-PT, the pertussis toxin antibody levels in each of these cohorts, those who have received WP and those who have received AP. So they have actually found not much of a difference in terms of the levels post the either WP or AP. So the important thing to remember is that make sure that your the children come back regularly for the immunization and that they do not miss out the boosters. So whether you do the WP or the AP, just make sure that they come back. It is known that the AP has a little faster waning as compared to the WP vaccine in terms of the antibody titers. So it's a marginal the levels are fall marginally earlier in following an AP as against a WP vaccine. So there is definitely no point of care in black and white saying that you have to prime with WP and then go to AP. This has just come out of practice. So as you rightly mentioned, probably these kind of papers will definitely throw more and more light for us in the days ahead. And this debate will continue for a very long time, WP versus AP. So the next question is, HBsAg is a better immunogen or the whole virus hepatitis B?
To be frank enough, I have not understood the meaning of this. But then, of course, hepatitis B vaccine contains hepatitis B surface antigen, and it is one of the very uh, good immunogens, to the best of my knowledge, because the protection offered by hepatitis B vaccine is great. Okay, and that's why hepatitis B surface antigen, no doubt, is a good immunogen. But I really don't understand what you mean by the whole virus hepatitis B, because the virus antigen which is used for preparation of the vaccine is hepatitis B surface antigen. I really don't understand what is the meaning of the latter part of the question. So anyway,
I'm
yeah.
not sure, probably the references to the newer vaccines which are coming out. We have
Okay.
what we currently have is a conjugate vaccine, but yes, adjuvanted vaccines are available in the US. I mean, in some parts of the world besides the US too, and
Okay.
they are much more immunogenic. So we don't have them anyway as yet in India. So we have to wait and see what comes into India.
Okay.
So the next question is identify vaccine potency and protection of AFI. I'm again not sure what.
I think that's a comment. Yeah.
Okay. The next question is about HPV-9. Given every year 3 doses after 30 years of age, is it okay?
I don't think there is any reference for this. The standard recommendations are, of course, in the 9 to 14 years, 0 and 6, and later on, 0, 2, and 6. I don't think this is something which is scientifically known as of now. Yeah. Okay.
Yeah, also currently HPV-9 is not licensed above the age of 26 years. So if you give it, do something which is not licensed, you're doing it off label. And certainly there is no role of giving it every year, uh, given every year. No, there is no role or there are no studies of repeated doses. In fact, even CDC mentions that once the individual has completed either 2 dose or 3 dose age appropriately, they are supposed to be protected for life. There is no data because we understand that the antibody titers are extremely high. The 9-valent gives almost a 98% efficacy against the vaccine serotypes, and those are the common ones which are responsible for malignancy subsequently. So there is definitely no data, there is no requirement for repeated doses. So the next question is, while administering Infendrix Hexa, forgot to dilute with Hib. So administered only DTAP, IPV, and hepatitis B, what should be done?
Yeah, I can understand this happens. As I told you, the one in the story that I told you, that varicella also, sometimes only the diluent gets injected and the lyophilized part remains like that. In case if it happens like this, what happens is that hip component which is left out. Many of my colleagues, they use normal saline, and maybe they dissolve that hip along with that normal saline, though it's not something which is practiced, but then rather it should not be. But then in case if only DTAP, IPV and hepatitis B has been administered and hib has been left apart, okay, then that particular hib which is in the powder form could be mixed with normal saline 0.5 ml and injected, though this is not a standard of care. This is only to complete that. But this is particularly true when you have to give a booster. So at that time also we have to be careful because a hib definitely needs to be given as a booster. Sumita, what is your opinion?
Sir, you're right. Hip protection is absolutely essential. We cannot leave the child unprotected to hip. So you have to administer definitely the hip component. And as you rightly mentioned, sir, the diluent. So there is a role of the diluents. We have to use the diluent as prescribed by the manufacturer. So there is absolutely, please, the message is that very clear, no using any other diluent. So kindly do not use another diluent, normal saline or anything else. Do not use a diluent. You have to administer, as we don't have a standalone hib currently, you have to give the whole vaccine, the whole component again, so that the child has a hip protection. Okay, please understand the excess antigen is not going to cause any damage to the child. Rather, the absence of the hip component is what is going to keep your child liable to hip infection, which we all know can be very severe. Hip meningitis, etc., is something which we all dread. So you have to do it. There is no other way out in the absence of standalone hibs. So
Yeah.
that's
Unfortunately, we don't have the standalone hib, and
yes.
that's why there is a problem. Okay. Yeah.
Yes, sir. So this situation, in fact, many a times we encounter in the immunocompromised, in those undergoing cochlear implants, etc., the slightly older children, adolescents, etc., where that is definitely a high risk factor and high risk situation, and you definitely need to give the hip vaccine. So uh, even adult physicians, ENT surgeons, etc., are using the vaccine which contains the hip, and they have not reported very high reactogenicity per se. So that's nothing, that's really not a point to worry about, but you have to ensure that the child or the adolescent is protected. So I think that's very important. So the next question is IAP stand on pre-exposure rabies vaccines.
Yeah, pre-exposure rabies vaccines are mainly given to the high-risk individuals, particularly those who are dealing with the animals, even those who are working in the jungles, also the postmen, and people who are more liable to be bitten by the dogs. And the IAP stand is, of course, to give three injections of this vaccine at 0, 7, and 21, and that is pre-exposure prophylaxis. It helps in a way that when a child rather or the high risk person gets bitten in real life situation, later on he need not be given all the full schedule. At that time the number of doses could be less, but basically it is, as of now, recommended only for the high risk individuals. Yeah.
Also, there is no requirement to use immunoglobulin even in cat 3 bites. So once there's already a pre-exposure prophylaxis
Right.
given, there is no requirement.
Right.
Uh, as of now, I don't think IAP has any definite stand on implementing it as a routine. But yes, on a case by case, if you discuss, especially the households with pets or wherein the children are likely to be playing with dogs, not only their own, probably neighbors or street dogs, yes, it's a good idea. Another very important category is the adolescents who go out and volunteer to take care of these, homeless pets, street dogs, etc. It's a very good idea to recommend pre-exposure to them as well.
Right.
So, yes, sir. Moving on to the next question. Can vitamin K and Hep B given on the same thigh at birth? Does vitamin K reduce immunogenicity of Hep B?
To the best of my knowledge, the vaccine and the vitamin, they could be given on the same side, provided there is a difference of 1 inch in between the two injections. There is no problem. And as of now, I have not come across any literature where I would be able to tell you about the immunogenicity of hepatitis B being affected by vitamin K. I don't see any reason why vitamin K should reduce the immunogenicity, but then I personally don't know the answer to this. Yeah.
No, sir, I don't think there is any interference. As you rightly mentioned, at least 1 inch, 2.5 centimeters interval between the vitamin K and the antigen. So, in fact, the recommendation is also you can give multiple antigens on the same thigh or on the same side or same limb, provided you maintain that interval between them. So, I don't think that is
Okay.
there's any interference. The next question is, should we remove the air present in the pre-filled vaccine syringe before administration?
Yeah, of course. So when you take a pre-filled vaccine syringe, it is always desirable that you remove the air. Only be careful that when you remove the air, the vaccine doesn't spill out. So you have to be extremely careful. But it is always desirable. I don't think there is any doubt about this. Yeah.
Yeah, if you are not very sure, like you mentioned, sir, that your vaccine spill out, then you can as well leave it at just that minimal amount which gets absorbed. So when it's from the manufacturer side with the PFS, it's not a serious concern there, even if you do not take it out.
Right.
So this is about PCV. A baby has been given PCV 13 at 6 weeks. Can she be switched to PCV 10 on 10th, 14th week due to affordability issues?
Personally, don't think this is right. As it is, we are getting down the number of antigens. In case if you step up from PCV 10 to PCV 13, logically it should be okay. But then even then interchangeability of these PCVs is better not done. People say that, give any vaccine, but give it, and that's fine. But then, in case if you are, easily getting one particular vaccine, then if availability is not a problem, interchangeability as far as possible should be avoided. And the cost difference in these two also is not much, PCV 13 and PCV 10. Maybe there is a difference of about 500 rupees probably at the, when they are purchased at a larger scale. That is what I think. Maybe Sumita, you can give your opinion about this,
Yes,
about
sir, you have rightly said.
interchangeability.
Yes,
Yeah.
you have rightly mentioned regarding interchangeability is really not recommended per se. But having said that, in the government, in the National Immunization Program, uh, up until now, they have been doing PCV 10 and 14. So from Serum Institute as well as the BE vaccine have come in, and I'm told now that the 10 valent is going to be phased out from the National Immunization Program. So they're going to do only 14. So they have been doing it. Yes, there have been different districts which receive, the stocks of either one of the two. So, well, from the NIP point of view, yes, you can do it. But as you rightly mentioned, you're coming down in the immunogenicity in terms of the antigen numbers. From 13, you're going down to 10. And please understand, 14 has, and it does not have all the antigens of 13. So you are not actually giving the child the protection against 6A, which is really required. So it's up to you to take a call. If affordability is really, really an issue, then well, yes, it's a end of the day, you have to give the child the protection of against the pneumococcal vaccine. So at least give something which they can afford to take. And if not, it's a good idea to send them into the NIP where anyways they're getting it all free of cost. So, but make sure that the child does receive at least one of any one of the pneumococcal vaccines. So it should not be,
আচ্ছা
should not,
হয়ে গেছে কোশ্চেন আনসার চলছে ভ্যাকসিন নিয়ে বললো প্রমোদ যে বললো ভালোই বললো
Dr. Kalpana, we can hear you, Dr. Kalpana. Thank you. So,
how come unmuted?
yeah, it's not a routine practice to be followed to interchange the brands because there is no data on immunogenicity of brand change, especially with pneumococcal vaccines. But as a one-off, well, in a special situation like that, I guess it's better to protect rather than to leave the child unprotected. So sterile water for Hib, I think we've already discussed that. First dose of HPV-4 taken at 20 years, now likes to opt for HPV-9. How do you complete the course?
Actually, this is a very commonly asked question that some people have taken HPV-4 earlier and then they want to go to HPV-9. In case if you want to, start with HPV-9, it has to be the entire, schedule of HPV-9. You cannot just say that I took three pricks of HPV-4 earlier and now whether I can get HPV-9 only as a single dose as a booster. No, that's not done. So as Sumita already told you, the HPV-9 is for 9 to 26 years females and 0 to 6, whatever the schedule is to be followed of three doses, particularly because it's above 20, needs to be followed. So there is no shortcut. Yeah.
Okay, so this is an interesting question here, sir. I have given tetraxim vaccine instead of pentaxim at 18 months. At 18 months, baby by mistake. What is to be done?
Yeah, actually, for tetraxim, there is no clear-cut answer. Though I told you that for Tdap, there is an answer that it is to be counted. It is not to be taken as invalid because some protection does occur, though it is not optimal. But tetraxim, which has DTP along with IPV. Now here, because pentaxim does contain other antigens also, and that's why those antigens will not be available for that baby. So again here, the availability of the Hib will be additionally a problem. So again, the question will come whether that Hib component from that pentaxim, rather this Infanix hexa to be taken, and again, give to be given with a diluent, that's again another story. Particularly remember that Hib component is important as a booster, and that will be something which is missing. Though tetraxim may give protection for DTP and IPV. That Hib also needs to be given. So you'll have to again somehow mix and match by taking Hib and then diluting with some diluent, maybe saline, which most of my other colleagues who have faced similar problem they do. But then there is no clear-cut scientific answer to what you are saying. But then that has to be just done off-label. Yeah.
Okay, next one is routine use of meningococcal conjugate vaccine is practiced by many. What is your opinion, sir?
Yeah, meningococcal conjugate vaccine is a very good vaccine, and the antigen is very good. So all those ACWY antigens are very good. They give almost 97 to 99% protection. And at an individual level, for those who can afford, and for those who are at a high risk, like those are having some chronic problem like lung problem, kidney problem, immunosuppression, steroids, and others where the chances of complications related to meningitis are very high, you can always give them proactively this particular vaccine. It is definitely dependent on the epidemiology of the disease in a country. So if it is less than 2 per lakh, which is the situation in India, then it is not to be taken in the government schedule. If it is between 2 and 10, then it comes under the intermediate zone. And in Africa and others where it is more than 100 per 1 lakh, obviously it is a priority. So as of now, this routine use remains arena of individual pediatrician, and particularly definitely for those I always say that starting from the alphabet H, the Hajj pilgrims, the hostelites, those who are going out of India, okay, at the age of 18, they do need this vaccine as a mandate because they have to go to US, okay, and always so many indications are there where even the military recruits where overcrowding can increase the risk of meningococcal disease. So all these high risk individuals, immunocompromised, HIV positives, asplenics, because meningococcus is a capsulated organism and which is opsonized in the spleen. So if there is a problem like sickle cell disease or a functional asplenia because of any other reason, then one has to be very very careful that they receive this vaccine. But as of now, I don't think it should be routine because our country has other priorities like typhoid and hepatitis A and others more than meningococcal disease. And so in the national schedule, as of now, definitely no. But at an individual level, depending on the individual case to case basis, and the medical condition of the patient, you can recommend it, but recommend it, inform them that this vaccine exists in the market and there is no harm if you take it, because particularly under the age of 1, what you need are ready-made antibodies. Okay, so meningococcal meningitis has a very short incubation period of 1 day. So within 24 hours, the world changes from here to there, so the child suddenly can become very serious. And that's why ready-made antibodies are very important, and that's why these babies need to have the protection. And one doesn't know as to when this particular problem would strike them. So that is something about this disease, but then not at a government level. Individual level, it all depends on one-to-one basis and the situation. Thank you.
Yes, sir, very well said. So it has to be on a one-to-one, but yes, not as a general recommendation currently in India.
Yeah.
The next question is about the birth dose of Hep B should also be administered by 24 gauge needle IM, or 26 gauge needle should be sufficient.
It depends on the muscle mass of that baby, and usually I use because this 26 number needle of 1 inch length sometimes becomes difficult to procure, and that's why this 24 number needle 1 inch many times is easily available, and that's why I have to resort to this 24 number needle. And because the depth is important, I told you hepatitis B, rabies, HPV, and influenza, 4 vaccines have to be given intramuscularly. There is no way out, and that's why the needle length matters. If you use a shorter length needle, the vaccine may go subcutaneously. Okay, and that's why it is better that you use the proper length of the needle. So more than the the gauge, whether it is 23, 24, 24, 25, 26, it is the length which is very important, because for some of these vaccines it has to go intramuscularly. Yeah.
Uh, Hib vaccine catch-up age.
Yeah. Catch-up age, I think hip is a disease predominantly under the age of 5 years. And in case if child has not received any vaccine containing hip component at all, even till the age of 5, then of course, as we do it for other vaccines, 0, 1, and 6 could be the schedule for hip vaccine, to the best of my knowledge. Yeah. But then after 5 years, I don't think hip vaccine needs to be given. Yeah.
So the maximum incidence of Hib is in the first 2 years of life.
Right.
Therefore, you have to ensure that any child who has missed Hib, which is very rare these days because we have the combo vaccines. So it's currently, I would say this is very a hypothetical question, but yes, please note that the maximum incidence of Hib is below the age of 2 years. Of course, this is besides the immunocompromised and all the other special conditions which Dr. Jog has already mentioned. But yes, below the age of 2, they should be covered with the Hib vaccine. Now, this looks like the last questions here, sir. One of my patients took 1 dose of HPV at 10 years of age. Now she has turned up at 20 years. For the second dose, will she be given a 3-dose schedule again, or only 1 dose at 20 years of age?
I personally don't know the answer for this. To the best of my knowledge, a lot of time has lapsed between the first single dose that the lady has taken, and maybe now she is almost, coming after 10 years. We understand that there is a principle of immune memory, and, the first dose would definitely create some immune memory. It depends on the vaccine, because single dose of HPV 4 as well as HPV 9, I understand that it gives very good protection even beyond 90%, single dose. But it also, I am also aware that the protection offered by the 2 doses or 3 doses lasts for almost 14 years. Okay. But then I am not aware of any study where a single dose given at the age of 10, what is the duration of protection? Because there are no studies with a single dose, to the best of my knowledge, with HPV 4, because this lady has taken 1 dose of HPV. It's not very clear whether it was HPV 4 or 9. HPV 9 doesn't have studies for 9 years as of now, 10 years also. So HPV 4 has studies up to 14 to 17 years, but the studies are for all the 3 doses, 0 to 6, and where the protection lasts for almost 17 years. That is, the real world data. But for HPV 9, there are no studies as yet. So I don't think I'll be able to answer this, because I am not sure about the real world data about single dose of HPV 4 given at 10. However, it will be prudent and wise to repeat the course at the age of 20 by giving 3 doses at 0, 2, and 6. That is absolutely personal opinion. And in case if Sumita, if you have any inputs, you can feel free to add to that.
Yes, thank you. I will probably beg to differ with you on this. So the single dose trials have been done extensively. I think we have the trials from Kenya, the Kenshi, the Doris trial from Tanzania, etc., where they have tried a single dose of HPV vaccine at different ages. So the Kenshi was from the 9 to 14 years, and the Doris was from the 14 to 25 years. So they were different cohorts who were tried, who were given a single dose of the vaccine. And besides this, we had our own Indian data. There was an IARC trial which had been started but got aborted after about 4 or 5 years of the trial for various reasons. So what happened was there in that cohort, if I'm talking about the Indian data per se, the IARC trial, and then of course the CVT, that's a Costa Rica trial, also threw up a lot of results. Now, in the Indian trial, there was a cohort who had received 1 dose. There were some who received 2 doses, and there were some who had completed the course of 3 doses. So they were able to do, this was probably a study wherein they looked at what data was collected, and they found that those who had received a single dose versus those who had received completed the course of 3 doses, there was not much of a difference in terms of the antibody response. So they checked the antibody response in these different cohorts, and they found that the levels, even with a single dose, was excellent, probably to the tune of 80 to 85%. So as against those who had completed all three, where it was about 95% and more. So definitely there is a role of a single dose. Now, I mentioned the Kenshi and the Doris trial. There also they have given a single dose of the HPV vaccine. All those which have been trialed there are the HPV-4 valent vaccine, and they have shown excellent results. So having said that, the current recommendation is not for a single dose in the private practice, if I may use that word, but ACVIP does not recommend a single dose as of now. So whatever studies are of single dose, that is related to the on a programmatic basis in terms of the what will probably come into the national immunization program. Now the next part of it is the time lag. So we understand that the HPV vaccines follow the prime boost. So we say 9 to 14 years, only 2 doses. So the first dose acts as a priming, the second dose acts as a boost. So that is the premise on which the dosing has been done. Once the child has received or the adolescent has received a single dose, he or she is primed to protection against the HPV antigens. So there is a development of the antibody response in the body. The moment the booster dose is given, it boosts up and the levels just zoom up. The antibody levels just zoom up. Now, what the CDC says is that as there is data with the efficacy of a single dose, the second dose, even if it is given after a time lag, it doesn't matter. So if an adolescent has got the first dose below 14 years, so which means if when I say 14 years, the counting goes on to 14 years and 365 days. That is before the 15th year onset. So any individual, any adolescent who has received the first dose between 9 to 14 years and comes for the second dose after any time beyond 5 months. You talked about the timing and the interval between the doses. So anytime after 5 months, it could even be 10 years or 15 years later, it doesn't matter. You need to complete the schedule by giving just 1 dose more. So as of now, the ACIP and the CDC recommend that as long as priming is done, there is definitely some amount of immune response. The moment you give the booster, the second dose, that's when the antibody titers get boosted. So as of now, the answer to this question is you just do 1 more dose and that individual is protected. Now, since she has taken the first dose at 10 years, if it was a 15-year-old or a 18-year-old, then of course the story is different. You will have to give again 2 doses, which would be whenever they come to you and see you, that would be the counted as dose number 2. And 6 months later, you call her back for the third dose, which will be the final, that would be considered the boosting dose in that individual. So as this is a 10-year-old, I think the question talks about a 10-year-old, just one more dose is sufficient. So I think with that, we have come to the end of this very wonderful discussion. So Apan, that's back to you.
Thank you, Smita ma'am. In fact, the audience who have listened to her, I just want to inform you that she is the ACVIP member and the main pillar of the IIP VAC course, which I am also undergoing on the second course. So I'm really thankful to you, Sumita ma'am, for moderating the sessions.
Thank you.
And Dr. Jog, as usual, has batted like Sunil Gavaskar. And he was so lucid during the dialogue session, it looks like just a story, sir. So thank you so much on behalf of West Bengal Academy of Pediatrics. As the president, I would really, I want to show my respect to you and Sumita ma'am also for coming for this, listen to the legends as the speaker, as the legend, and Sumita ma'am for the moderation. Now I will request Dr. Subhashish Bhattacharya, our scientific chairpersons of West Bengal Academy of Pediatrics, to give vote of thanks to both of them and to the audience. Over to you, Subhashish.
Thank you. Actually, this is excellent discussion by Dr. Pramod Jog, and it's so lucid and so this thing easy way of the discussion, sir. Hats off to you. It's excellent discussion, and also Sumita ma'am has discussed a lot of things, lot of questions, and the interaction was excellent. So thank you all, Sumita ma'am and Dr. Pramod Jog, for presenting this today's evening presentation. Excellent, and we learned a lot from you. And I must thank the Dr. Shopon Rai, President, and our all dignitaries of West Bengal IIP, and who attended this excellent session. Thank you all. Thank you.
Thank you.
Absolute pleasure. Thank you, sir. Thank you.
Thank you. Thank you.
Thank you,
Good
Jog
night.
sir.
Okay.
Thank you. Good night.
Bye.
Good
Good night.
night. Good night.
Good night.
So Aditya, you can stop.
Oh, yes, sir.
Thank you for the extraordinary this flow. Thanks again.